Imagine a medical treatment, right, that promises to reverse female sexual dysfunction, and it uses nothing but a highly calibrated spin cycle of your own blood.
Yeah, completely autologous, nothing synthetic.
Exactly. And get this, it boasts a documented clinical side effect of spontaneous orgasms.
Which is wild to even read in a medical paper.
Right. I mean, you would think a therapy like that would be plastered across the front page of every single medical journal, like immediately integrated into standard gynecological care.
You would think so, but it's actually not.
No. Instead, it is this fiercely debated, fiercely trademarked procedure, and the medical establishment still largely categorizes it as, well, investigational.
Yeah, it sits squarely in this really murky territory. It's somewhere between a genuine medical breakthrough and a highly lucrative aesthetic enhancement.
Right.
And because of that positioning, it generates just an immense amount of polarized data.
Which is exactly why we are unpacking this for you today. Welcome to the deep dive. We are asking a very specific, highly provocative question on your behalf today.
The big one.
Yeah. Will sex actually feel better after the O shot?
Such a loaded question.
It really is. And to get you a real answer, we are completely ignoring the glossy clinic brochures.
Right.
We went straight to the raw data.
The best place to go.
Always. We have a massive stack of sources for this deep dive. We're looking at everything from a 2023 systematic review in the journal Biomedicines to a really critical 2024 clinical trial analysis out of Oklahoma State University.
Yeah, that one is fascinating.
Right. And we're going all the way up to a brand new, heavily debated 2026 study in the Obstetrics and Gynecology Green Journal.
And that spread of sources is just crucial for you to understand this, because the Green Journal is a heavyweight in women's health.
Oh, absolutely.
So pitting its findings against those systematic reviews and the clinical trial registries, it gives us a chance to actually see where the marketing hyperbole ends and the biological reality begins.
Okay, let's unpack this, because before we even touch on the concept of better sex, we need to look at the substance itself.
Right. What are we actually injecting here?
Exactly. We are talking about platelet-rich plasma, or PRP.
Yeah.
And this isn't, a synthetic pharmaceutical compound cooked up in a lab somewhere.
No, it's an autologous treatment, meaning it is harvested entirely from the patient.
Your own body.
Right. And the process itself is, on the surface at least, surprisingly straightforward. Blood is drawn from your arm, much like a standard cholesterol check.
Okay.
And then that blood is placed into a specialized FDA-approved centrifuge.
And from my reading, that centrifuge isn't just like a basic medical salad spinner.
No, definitely not.
It's all about density stratification. It spins at this highly specific, calibrated speed to force all the red and white blood cells down to the bottom.
Leaving that golden serum suspended right at the top.
Right.
That golden serum is the plasma, and it is heavily concentrated with platelets. In a clinical PRP preparation, you are extracting a serum that contains anywhere from, 1.6 to 6 times the normal concentration of platelets found in circulating blood.
So it's essentially like putting your blood into a blender to make this physiological smoothie, right? And extracting just the elite repair crew.
That's a great way to look at it.
Because you're bypassing all the rest of the blood and sending this hyper-concentrated repair crew directly to the tissue that needs a remodel.
Exactly.
I was really trying to conceptualize what that actually means for the tissue. Like, we know platelets are the cells that rush to a cut on your finger to stop the bleeding, right?
Yeah, the first responders.
Right. But the sources keep talking about growth factors, specifically VEGF and PDGF. So if we think about vaginal tissue that has lost its sensitivity or lost its blood supply due to aging or estrogen drops, it's basically like a neighborhood experiencing rolling blackouts.
Oh, I like that analogy.
Yeah, because the nerve endings just stop firing. They literally don't have the physiological power supply anymore.
And that maps perfectly to the actual mechanism of action.
Yeah.
Because injecting this hyper-concentrated PRP isn't like injecting a synthetic dermal filler.
You want just plumping it up.
No, you aren't just adding cosmetic bulk or a temporary cushion to the tissue. You are delivering a massive payload of biological signaling flares.
Wow.
Yeah. So PDGF, which is platelet-derived growth factor, it essentially wakes up dormant fibroblasts in the tissue.
Okay.
And it signals them to synthesize brand new collagen III.
So it's actively rebuilding the structural integrity of the area.
It goes even further than that.
Yeah.
You mentioned VEGF earlier, vascular endothelial growth factor.
Right.
Its primary mechanism is angiogenesis, which means it literally forces the body to grow a whole new network of healthy blood vessels.
Wow.
So to use your analogy, the PRP is laying down brand new fiber optic cables to turn the neighborhood's power back on.
Yeah.
You're fundamentally remodeling the vaginal lining and regenerating those nerve endings from the inside out.
But because these growth factors rely entirely on physical proximity to work, exactly where you inject them changes the biological outcome completely.
Oh, absolutely. Location is everything.
And that anatomical precision, I mean, it seems to be the center of this massive trademark battle over what actually gets to be called the O-shot.
Yeah, that branding distinction is a major variable in all the clinical literature. The O-shot is not just some generic term for vaginal PRP.
Right, it's highly regulated.
Right. It is a highly specific patented protocol. It was developed by Dr. Charles Runels, and it mandates exact preparation methods and, crucially, very specific injection sites.
The anterior vaginal wall and the clitoris.
Yes, the protocol requires deploying these growth factors directly into those two highly sensitive structures. The anterior vaginal wall is the area we commonly associate with the G-spot.
Okay.
And the clitoris is obviously the epicenter of female sexual arousal.
Which makes perfect biological sense. If you have this hyper-concentrated repair crew, you want to deploy them to the most nerve-dense structures available.
Exactly.
But this brings us to that fascinating controversy from April 2026. I was reading that Green Journal study, and initially, man, it looked like a massive, unequivocal slam dunk for the procedure.
It really did.
Yeah. They ran this randomized controlled trial testing PRP for female sexual function, and the treatment group showed clear, statistically significant improvements over the control group.
And the media certainly framed it as a definitive victory. They were using the term O-shot generically in almost every single headline covering the study.
Right. But then Dr. Runels, the actual inventor of the protocol, jumped into the public discourse with this massive caveat.
Yeah, he pointed out a pretty big flaw.
He pointed out that the researchers in that study entirely skipped the clitoris. They only injected the anterior vaginal wall.
And he argued that while the study validates the foundational biology of PRP, proving that even a localized partial treatment improves tissue health, omitting the clitoris severely compromises the magnitude of the arousal response.
So my question to you is that a biologically sound critique? Or is that just a physician aggressively protecting a highly lucrative trademark from these generic clinical trials?
It's honestly a bit of both. But the biological critique holds immense weight. I mean, the clitoris contains an incredibly dense network of thousands of nerve endings.
Right.
Anatomy dictates nerve density. So if the stated goal of the procedure is to treat anorgasmia, the inability to orgasm, and you intentionally avoid injecting the growth factors into the primary organ responsible for orgasmic climax,
You're kind of missing the point.
yeah, you are undeniably altering the clinical outcome. The exact anatomical placement is a vital physiological variable.
And whether that anatomical placement actually translates into a better sexual experience, I mean, that brings us to the absolute core of this deep dive, the efficacy debate.
Does it actually work?
Exactly. Does this localized injection deliver on its promise? Because when we look at the positive data, specifically that 2023 systematic review in biomedicines, the numbers are pretty striking.
They are. They aggregated data from 172 women across multiple studies, and they utilized validated clinical questionnaires to measure the outcome.
Which is important, right?
Very.
Yeah.
It adds a crucial layer of objective tracking to what is inherently a very subjective experience.
And the outcomes weren't just like a marginal bump in satisfaction. The women in these studies reported profound improvements in desire, arousal, natural lubrication, and orgasm intensity.
Yeah, across the board.
But what really stood out to me was how they tracked baseline sexual distress.
Right, you're referring to the shift in diagnostic categories.
Yeah.
So many of the women entered these trials with scores that firmly classified them as experiencing clinical sexual dysfunction. But following the PRP treatments, a statistically significant portion of that cohort shifted completely out of the dysfunction category.
Wow.
Yeah, they moved straight back into the normal range. So that is not just a lifestyle enhancement, that is a massive mitigation of psychological and physical distress.
It sounds like an absolute miraculous intervention. But here I want to pivot to the 2024 Oklahoma State University data.
Ah, yes. The cold water.
A massive bucket of cold water on this hype. because they didn't just look at the shiny, published success stories like that 2023 review. They went digging into the raw U.S. National Library of Medicine database to find registered clinical trials that were initiated but maybe never saw the light of day.
And that is such a critical step. Looking at trial registries is, honestly, one of the most effective ways to spot publication bias.
Because you only publish what works.
Exactly. Researchers are far more likely to publish a study that proves their hypothesis than a study that shows absolutely no effect.
And the Oklahoma team found the hidden data. They identified 18 relevant trials using PRP for female sexual dysfunction. And only 33% of them had even been completed.
Which is a huge red flag on its own.
Right, and of those, only 3 had actually published their findings. But the true gut punch for anyone considering this procedure is their final conclusion. Out of the studies they analyzed, not a single one found statistically significant improvements in sexual satisfaction or arousal.
It is a jarring juxtaposition. On one side, you have a systematic review showing profound, category-shifting benefits. And on the other side, an analysis of trial registries suggesting a total failure to clear the hurdle of statistical significance.
So how do we synthesize that for the listener? I mean, how can 2 diametrically opposed realities exist within the exact same decade of data?
Well, if we connect this to the bigger picture, you really have to look at the environments where this data is generated. There is a vast chasm between subjective, self-reported patient satisfaction in a boutique clinic setting and the grueling objective hurdles of a large-scale, double-blind, placebo-controlled clinical trial.
Ah, I see.
In a private clinic, a patient is highly motivated. I mean, they are paying thousands of dollars out of pocket.
True.
Furthermore, there is a notoriously powerful placebo effect inherent in receiving any novel biological injection.
So the sheer expectation of healing triggers an actual physiological response.
Yes, precisely. Add to that the difficulty of measuring something as deeply subjective and psychologically complex as sexual arousal in a sterile clinical trial environment.
It's basically impossible to measure purely objectively.
Right. And these clinical trials often use really small sample sizes. Not to mention, the preparation protocols vary wildly between institutions.
Which means we need to be incredibly clear to you listening right now. Vaginal PRP is not a magic button.
No, it's not.
It is a biologically plausible investigational tissue support treatment. If the root of a woman's anorgasmia is purely psychological or related to relationship dynamics, injecting growth factors into the tissue is not going to fix the problem.
And that is the most medically responsible way to frame it. The biology is sound, absolutely, but the highest echelon of objective, randomized scientific proof is still, frankly, attempting to catch up to the clinical enthusiasm.
But this raises such an obvious question. If the data on orgasms and peak pleasure is still trapped in this fierce clinical debate, why are so many women actively seeking this out right now?
That's the real question.
Why are they paying massive out-of-pocket fees? And when you look closely at the sources, the answer becomes obvious. It's because this treatment is addressing conditions that extend far beyond just reaching a climax.
Yes. You are touching on the medical reality of genitourinary syndrome of menopause, or GSM, as well as dyspareunia, which is the clinical term for painful intercourse.
Right. And one of our sources highlights that GSM affects roughly 50% of postmenopausal women. We aren't talking about a niche issue here.
Not at all. We are talking about half of the female population over a certain age. GSM is driven by the systemic drop in estrogen. So when those hormone levels plummet, the biomechanics of the vaginal epithelium completely break down.
It just stops functioning the same way.
Exactly. The tissue loses its elasticity. It physically thins out. The natural lactobacillus bacteria deplete, which alters the pH and leaves the tissue highly susceptible to recurrent infections.
It's a severe structural degradation.
It really is.
The tissue becomes dry, brittle, and prone to micro-tearing. I mean, it's like trying to fix the foundation of a house before you even start worrying about the interior decorating. For a massive percentage of these women, sex isn't just a matter of low libido or missing an orgasm. Intercourse is excruciatingly painful.
And that is precisely where PRP seems to demonstrate its most undeniable value. By utilizing that VEGF and PDGF to stimulate angiogenesis and collagen production, the therapy physically thickens the vaginal lining.
It rebuilds the foundation.
Yes. It restores mucosal moisture and drastically reduces the localized inflammation that's causing the dyspareunia.
So for women who have survived breast cancer or those who simply cannot take synthetic hormone replacement therapy for whatever reason, this represents a non-hormonal regenerative lifeline.
A huge lifeline.
You literally have to heal the microtearing and resolve the severe pain before pleasure is even on the table.
And the applications extend to structural support as well, particularly regarding stress urinary incontinence, or SUI.
Right, SUI. That's the involuntary leakage that occurs when laughing, sneezing, or jumping, usually due to weakened pelvic floor structures from childbirth or menopause.
Exactly.
And the theory is that injecting PRP into the anterior vaginal wall helps bulk up the tissue surrounding the urethra, providing better physical support.
It is a heavily utilized application of the therapy in clinics right now. However, we do have to remain objective about the comparative data here.
Okay.
The NICE guidelines, that's the National Institute for Health and Care Excellence in the UK, they analyzed a randomized trial that directly compared PRP against a surgical midurethral sling, which is the traditional surgical intervention for SUI.
So, did the autologous blood treatment actually outperform the scalpel?
It did not. The surgical sling still produced superior, more definitive objective scores for halting the leakage.
Good to know.
Right. PRP is a highly viable alternative for women who are contraindicated for surgery or who simply refuse an invasive procedure. But the data does not currently support it as a replacement for the surgical gold standard.
So it is a powerful tool, but not the definitive sledgehammer.
Exactly.
So for you listening, if you have absorbed all of this biology and you're actually considering sitting in that clinic chair, let's talk about the physical tool. What is the safety profile of injecting concentrated platelets into such a sensitive area? And what are the documented anomalies?
But the safety profile is undeniably one of the most compelling arguments for PRP.
Yeah.
Because it is autologous. It's your own blood. Your immune system recognizes the material as its own.
So no rejection.
Right. There is virtually zero risk of allergic reaction or tissue rejection.
And that 2023 review tracked the adverse events meticulously. Out of 317 women across 12 different studies, only 3 experienced any side effects whatsoever.
Which is an incredibly impressive safety margin.
Huge. But we have to look at what those 3 specific side effects were.
Right. Well, one woman experienced temporary urinary retention, basically a mild difficulty emptying the bladder that resolved on its own within a few days.
Okay, and the other 2?
The other 2 women experienced what the clinical literature officially categorizes as temporary continuous arousal and spontaneous orgasms.
Here's where it gets really interesting. You just know there are aesthetic clinics out there framing that as a premium feature.
Oh, without a doubt.
Like, come get the O shot. Warning. May cause spontaneous climax while reviewing quarterly earnings reports.
It sounds like an absolute marketing dream. But biologically, it is actually a symptom of temporary neural overload.
Wait, walk me through that. What does that mean?
Okay, so when you take tissue that has been functionally dormant or structurally degraded,
Yeah.
and you suddenly introduce a massive, hyper-concentrated spike of VEGF and nerve growth factors, the local neural network is just overwhelmed.
Oh, wow.
Yeah. The previously dormant nerve clusters essentially misfire until they acclimate to the newly restored blood flow and signaling environment.
That is wild.
It is. But it is a rare occurrence. I mean, only 2 documented cases in that wide review. And it resolves completely as the tissue stabilizes. So it's proof of how potent the nerve regeneration can be, but it is a biological anomaly. It's not the standard patient experience.
That makes a lot of sense. The system just gets flooded with signals and needs time to recalibrate.
Exactly.
What about the logistics of the treatment itself? You don't just walk out of the clinic 30 minutes later with fully remodeled tissue, right?
No, not at all. The clinical protocols generally require 1 to 3 sessions, spaced about 4 weeks apart.
Okay.
And the biological reality is that tissue remodeling takes time. Patients typically do not see the peak results until about 3 months after their final injection.
3 months.
Yeah, because the fibroblasts literally need time to synthesize that new collagen network.
Wow. And there is also a massive physiological caveat regarding medication that anyone undergoing this procedure absolutely must understand. The sources emphasize a strict ban on NSAIDs.
Yes. Patients must avoid non-steroidal anti-inflammatory drugs, things like ibuprofen, naproxen, or aspirin, for a significant window before and after the treatment.
But why does a standard painkiller disrupt the procedure?
Because the entire premise of PRP relies on triggering the body's natural inflammatory healing cascade.
Oh, right.
Platelets initiate repair through localized controlled inflammation. And NSAs are explicitly designed to shut down the inflammatory pathway.
So if you take an ibuprofen to manage post-injection soreness?
You are chemically blunting the platelet activity.
Yeah.
You effectively neutralize the exact biological mechanism you just paid thousands of dollars to initiate.
You are literally hiring an elite repair crew and then immediately handing them a chemical stop work order.
Precisely. And it is also critical to remember the regulatory stance on all this. Despite the robust underlying biology and the thousands of successful clinical outcomes, major medical bodies officially classify vaginal PRP as investigational.
Right. They acknowledge its potential, but they are holding out for larger, long-term, standardized trials before integrating it into routine clinical guidelines.
Yeah, the wheels of clinical consensus turn very slowly.
They really do. Okay, so what does this all mean? Let's bring this home for you listening. We asked if sex will feel better after the O shot.
The big question.
And the truth is, vaginal PRP is not a guaranteed FDA-approved magic wand that works identically for every single woman. The clinical trials are still fiercely debating the exact statistical significance of its impact on pure pleasure and arousal, and separating the placebo effect from the actual physiological response is incredibly difficult.
Yes.
But underneath all the trademark disputes and the glossy clinic marketing, there's undeniably sound biology here. It utilizes your body's own localized repair mechanisms to actively regenerate blood vessels and nerve endings.
Right.
It is treating genuine pain, severe tissue fragility, and the structural degradation associated with menopause. It is real science performing real remodeling, even if the clinical consensus is still catching up.
It really represents a fundamental shift in how we understand and support female tissue health. And if we connect this to the bigger picture, it raises an incredibly important question I want to leave you with today.
Let's hear it.
If we possess a biologically sound treatment derived entirely from a woman's own blood, with an exceptionally low risk of adverse effects that can demonstrably restore tissue integrity, relieve excruciating pain, and potentially return her sexual function without relying on synthetic hormones or surgical intervention.
Yeah.
What does it say about the priorities of our modern medical establishment that this therapy is still largely relegated to the realm of expensive, out-of-pocket aesthetic luxury, rather than being rigorously funded and integrated into standard, accessible gynecological care?